Good afternoon, everybody. As Heather said, my name is Christian Yantorno. I'm a Vice President of Account Management here at Corporate Synergies. Delighted to be with you today in our continuing ongoing series of controlling out of control healthcare costs and pharmacy costs in the case of today's presentation. The name of the presentation is aptly described as, does anyone object to runaway pharmacy costs? And we're going to talk about how you can best object to these runaway pharmacy costs today as we go through the presentation. But before we do, it's probably best that we get into a little bit of an overview of where we are in the current pharmacy landscape. So in terms of an overview, I think it goes without saying that at this point, we've all been seeing that drug prices in the United States are too high, but more importantly, that they're continuing to skyrocket out of control. Now, this continued skyrocketing of prescription drug prices has put enormous pressure on the entire healthcare system, but patients specifically are feeling it, and that works itself over to employers feeling it and providers feeling it as well. When we consider the total cost of healthcare delivered through employer-sponsored health programs, we're seeing prescription drugs grow as a percentage of the total cost dramatically. Used to be a few years back, might only be 10 or 15%, but at this point, we're seeing drug prices constitute upwards of nearly 20% of overall healthcare spend on employer group plans and climbing. So why are these costs out of control? Well, there's two factors that we're going to hone in on today, but the first one I'm going to hone in on is what we call direct-to-consumer advertising costs, or DTCA, as one of the primary problems that's unique to the United States. And the reason I bring this up as unique to the United States is I'm sure that there's not a single participant on today's webinar that hasn't seen drug commercials ad nauseum for the better part of 30 years at this point. Direct-to-consumer advertising saw its biggest jump back to what we know it as today in terms of these commercials that we all see on TV about in 1997. Now, interestingly, direct-to-consumer advertising, you'll only see it in two primary countries in the world, the United States and New Zealand. So why is that the case? Well, because there's an opportunity to make money. In terms of spending on it, you'll see that drug companies have spent nearly $4.5 billion on direct-to-consumer advertising in 2014, and that opportunity then grew for them to spend upwards of $6 billion on it in 2018 and growing. And it goes without saying that any industry that's going to spend $6 billion on advertising is only doing so because they believe the payoff will be much greater, and certainly has been in the case of the pharmaceutical industry. It's not that this has gone unnoticed. There's a point here that we're making that the American Medical Association proposed an outright ban on this back in 2015. And the quote is interesting. They argued that a growing proliferation of ads is driving demand for expensive treatments despite the clinical effectiveness of less costly treatments. So we've all been bamboozled into a world where we're buying drugs similar to the way we buy a pair of designer jeans in a sense. It's become big business to the tunes of billions and billions of dollars. This chart is illustrating for you between 2010 and 2020, the costs of drug expenditures within the United States in those billions. So if we go back to 2010, the total US prescription drug expenditures were $253.4 billion. That number climbed upwards in 2020 to $348.4 billion in drug expenditures within the United States and growing. Now, why else are costs high? It isn't exclusively direct-to-consumer advertising, although that is pernicious in the way it's made us go about how we purchase prescription drugs. But the other culprit that I'd point my finger to would be the cost of specialty medications. Specialty medications remains one of the fastest growing areas of pharmacy spend. It accounts for nearly half of total drug spend right now. And you may recall in the preceding slide when I was talking about $248 billion in expenditures in 2020, well, specialty spend could reach $310 billion alone by 2030. An example of a specialty medication, Humira. Humira is the #1 biologic. It generates over $20 billion in annual revenues. And as a measure of the growth in cost and utilization, this is critical for health plans because this is going to be the piece of the equation that leads to those skyrocketing costs. To have the overall healthcare pie look at pharmaceuticals rising from 20% of spend to upwards of 25% and eventually 30% of spend, as it could go with the advent and the specialty medications on the market. Now, specialty medications are also big business for the big pharmaceutical benefit managers. On this slide, we're illustrating some of the leading pharmaceutical benefit managers and the percentage of net pharmacy benefit spending for each of them in 2020. And you can see that on average, this is working out to approximately half of their total spend. Just the specialty, never mind all the other drugs, is 52%, 51%, and so on the chart. So how do we address it? Well, a starting point is picking the right prescription benefit manager and making sure that that prescription benefit manager brings some real-time solutions and analytics to the table that can help to address the root problem. Now, we've honed in on a couple of options here: alternative funding sourcing, international sourcing, mail order, formulary management, utilization review, and then rebates as well. But what we're going to hone in on today are two of the most important pieces: the alternative funding sources or premium assistance programs, as well as international sourcing. Okay, so starting off around the prescription assistance programs or PAP programs. We were talking before during the direct-to-consumer advertising about the, basically how we can't get away from these commercials on television. And many people have probably already noticed that when you see these commercials on television, that one of the throwaway lines at the end of the ad will be an offer from the narrator that if you can't afford your medication, AstraZeneca or Eli Lilly may be able to help with the cost. Well, that throwaway line at the end of the commercial is an important line from the perspective that if you're working with the right prescription benefit manager, those right PBM partners will know which drugs have those programs through which manufacturers and be able to potentially tap into them to lower costs. So in a situation where you have a PBM partner that can do this, they could potentially be set up in a situation where they'll be able to, when a person is identified as taking a drug that has one of these prescription assistance programs, they can make an outbound call directly to the participant to make them aware that the drug has that program, and then help them fill out any paperwork associated with signing up for that program, sort of a white glove service standpoint, to be able to put the participant in a situation where the prescription drug will still be made available to them, but now it will show up on their doorstep, mailed directly to them by the manufacturer, and their cost is reduced to almost nothing. Whereas before, especially those that are on a high deductible health plan, may see astronomical cost. Now, obviously, that's the benefit to the participant. The benefit to the employer will typically be upwards of a 90% savings off the drug cost if a prescription is identified as having one of these programs available. These programs have typically been made available based on income. Right in the commercials, they say if you can't afford your medications, the manufacturer may be able to help. So many of the questions will resort back to annual earnings and income and so forth to see if people can qualify. But for those that can, these are invaluable programs to help reduce the overall cost. Now, many drugs obviously are either not going to have one of these programs made available, or the participant in question may exceed the income thresholds where they potentially could qualify. And this is where I'm going to hone in on the second feature that we said we would focus on today, which is international sourcing. It is no secret to anybody on this call that we pay amongst the highest costs for prescription drugs in the entire world right here in the United States. So working with a PBM partner that can tap into international relationships and international sourcing opportunities to be able to source those drugs, Canada being an example, would lead to a reduction in cost, all for drugs that would be shipped to the participant still in the manufacturer packaging, so you know it passes quality and safety metrics. So Exact same drug coming to the person's doorstep would come in a situation where a person might be used to opening their door and seeing the drug on their doorstep. They would still open their door and see their drug on the doorstep. The only difference might be that when they open that package, perhaps it has a wrapper on it with a Canadian maple leaf. And that exact same drug shipped to them from an international location would then be a savings of between 30 to 90%, depending on which drug and the sourcing methodology involved. So a question comes into play. What about safety? Is this safe? Well, let's pose the question this way. Look at it from a standpoint of the fact that right now, if you're taking a medication that's coming to you through the mail, there's a good likelihood that that drug already was manufactured overseas. So when it was manufactured overseas, it was shipped to the United States. Then the price was dramatically inflated because when they landed in the United States, it was then shipped to you. Versus a scenario where the drug is manufactured overseas, it's then shipped to a different destination overseas and then shipped to you. Still in the manufacturer's packaging in both cases, still manufactured at the same plant in both cases. So where's the safety issue? Because if it's still in the manufacturer packaging, it kind of debunks the notion that that could be a problem. And the savings are too much to ignore. Basically, if you look at this, we've given some examples of some of these TV drugs that we've been talking about. All the drug names that you can see on this slide, Januvia, Trulicity, Stelara, Eliquis, all four are advertised on television, and all four come at a cost that has helped to lead to the problem that we have faced today in terms of the ever-escalating cost of prescription drugs. The average United States cost is illustrated here. Januvia at $466 a month. Trulicity at $839 a month. Stelara, very expensive, $23,500 for an 8-week treatment. And Eliquis at $476 a month. Working with the right PBM partners, there are international sourcing opportunities to be able to get those exact same drugs at $98 a month, $410 a month, $12,000 per 8 weeks, or $105 a month in the case of Eliquis. These are dramatic savings that add up and benefit the plan and help to keep costs low. Working with the right PBM partner also may lead to a place where you're able to have the breadth and depth of the number of drugs that could potentially be sourced on an international basis, apply out to even cold chain injectables, where working with the right partner, they'll have a process down to ensure the quality of a cold chain injectable arriving at your doorstep, still in a temperature-controlled environment. Now that's the international sourcing. We were talking before about the premium assistance programs. We gave an example of one pharmaceutical benefit manager here that actually does do work in this space, working with the prescription assistance programs. And we'll hone in on Humira. We were talking about it before as one of the most widely known specialty medications. Humira has a cost typically annually of $63,600. And think about that. An otherwise healthy person on your plan that just takes Humira is costing the plan $63,000 a year. Well, if their income is below the threshold where they can qualify for a prescription assistance program, that cost could be potentially reduced in this example to $10,800. And I can attest that's the case because I had a participant on one of my plans that was able to qualify for the prescription assistance program on Humira. And sure enough, that $63,000 claims is off the books, reduced to under $11,000 in expense for that employer. That specific participant in this example was on a high deductible health plan. He had to pay the entire cost of that prescription drug until he satisfied his deductible. And then even after the deductible was satisfied, he had cost share. That's out the window. He doesn't have that cost anymore because now he's qualified for that drug to come to him at no cost to him and a dramatically reduced cost for his employer. Januvia, same story, a $5,400 annual cost for that drug. With a prescription assistance program in play, it could be reduced to $1,800 a month. So what are the keys to a successful program? Well, the keys to the successful program really are all parties being aligned, human resources, your broker partner, the third-party administrator, and the prescription benefit manager have to work together to help make these programs a success. It also matters to make sure that in the program, you have the appropriate amounts of both sticks and carrots to ensure that you're going to succeed. Now, from a stick standpoint, the program should be structured in a manner in order to achieve optimal savings where if a participant is taking a medication where it's identified that they can take their drug and get that drug shipped to them internationally or potentially through a prescription assistance program, it should be mandatory for the participant to work through that program to see if that cost savings can come into play. So the plan can obviously save an inordinate amount of money, but that's where the carrot comes in. So the participant can also save money. A suggested best practice would be that if a drug is identified where you could potentially get international shipping, you waive your copays, waive all cost share for the participant. And if they're getting the drug through a high deductible health plan, simply waive all cost share after that deductible's been satisfied. Thinking being, if on average your participant is taking an expensive specialty medication, let's say costs about $60,000 a year. If that drug can be imported from Toronto, Canada, and have the cost reduced to $28,000 a year, a savings of $32,000 to the plan, it begs the question, do you really need the participant's $50 copay every month? No, because the plan has already won. It's saved an inordinate amount of money. So bring the employees into the process to help get their support for the process by also giving them a win. But by the use of a mandatory approach of saying if it's identified that this program is out there, it would be malpractice on our part not to take advantage of those savings opportunities when it's the same quality drugs. In conjunction with that reward of waiving cost share, we've seen our clients save on average upwards of almost 30% on their total pharmacy spend. Now, what about those big rebates, right? A lot of people that have carved out pharmacy programs today are used to receiving large rebate checks on a quarterly basis. I would submit to you that a well-designed pharmacy program, you wouldn't see those big rebate checks because those big rebate checks that are coming back to you are a percentage of your total spend being returned to you. So the lower the rebate, the more we've managed the cost of the program as a whole, which is what this is all about in the first place. So we've talked about the fact that all parties have to be aligned: HR, broker, TPA, prescription benefit manager. And that might even involve phone calls, ongoing monthly status calls to make sure that all parties are on board, make sure that all parties understand the marching orders, and also talk about individual cases that come up for participants on the program to make sure that they're getting the medications that they need, because safety comes first and they have to get their medications first, and then to make sure that the cost savings follow. Some of these prescription benefit managers in many cases will maintain a domestic pharmacy inside of the United States. So that way, if there's any question of a shipping arrangement where a person's getting a medication, it won't get to them in a timely manner, it can be the case that they could ship it domestically in the United States to make sure that the number one importance is that the person gets their medication in a timely fashion. And then in month 2, when shipping's back on track, then the participant can make sure that they get their drugs for the cost savings that we've been discussing. Now, a question did come in through the chat feature. Is there a process in place for the member to get the drug if there's a delay in international shipping? And I think what we just covered right there actually hits that. It's key to work with a prescription benefit manager that not only taps into these programs, but does maintain a domestic pharmacy. So that way, if there's any issue with shipping, people can make sure that the most important piece of the equation is that they get their medication in a timely fashion. I'll open this up to further questions at this point.
giving everybody about another minute or two. Perhaps they're typing for you, Christian.
Sure. So, question in the chat feature. You mentioned Shield PBM. Are they set up with any particular TPA and which one? So Shield was a good example. They run their own third party. They run their own PBM, and they are set up with certain TPAs in the industry. So that's a great question, because you want to make sure that any PBM partner that you utilize that can bring some of these solutions to bear is integrated with the TPA that you're going to be working with. So that can lead to questions to make sure in advance, if you're doing an RFP, that you check with the PBM partner or the TPA that they are synced with one another or can be synced with one another should you move forward. Well, I want to thank everybody for joining us. Hopefully this session was helpful. It's a rising inordinate amount of our total overall healthcare spend, but there are methods out there to be able to combat it. And using some of these solutions, it can keep in mind safety. It can keep in mind the importance of making sure that people have medication adherence while also bringing in tremendous cost savings, because we're overpaying in the United States, and it doesn't have to be that way. But thank you very much to everybody for joining.